So thank you to Dr. Ann and Dr. Smith for inviting me to be your lunchtime entertainment. I'm going to diverge a little bit from the talks earlier. I'm not going to present on a single clinical trial during my talk. But when I was kind of going through my talk last night with a couple of colleagues, I realized that some of these slides, they do really pertain to what you guys should be thinking about in clinic. But a lot of these slides also kind of give an introduction to what I'm doing as a genetic counselor. So if you're sitting in the room and you haven't worked closely with genetic counselors before and you're not really sure what I'm doing with my patients, you're not alone. So I will kind of go through, there is one family history that I'm going to go through, so I kind of describe what I'm looking at in these pedigrees. And also when I'm taking a family history and I'm asking about cancers in the family, sort of what I'm assessing for this patient. So my objectives are to review genetic syndromes that increase the risk for cancer and also identify guidelines for referring these patients that you're seeing to a genetic counselor. Just a little bit of fun facts. We know that approximately, at least we predict that approximately 5 to 10% of cancers are due to a hereditary cancer syndrome. And these are really 5 to 10% of cancers that we feel are due to one germline mutation. So this isn't like a combination of mutations that you inherit from your parents and also environmental factors. This is if you have one mutation that you're born with, you're already predisposed to getting certain types of cancers. There are many, many genes that we feel are associated with developing cancer during our lifetime and increasing above general population risk. For the most part, we don't really understand how a lot of these genes interact with each other and with environmental factors. And so as I go through some of these hereditary cancer syndromes that we do know about, I'm really kind of focusing on just 30 genes that we know cause a very high risk for increasing the risk for certain types of cancer. So that's a small fraction of the 600 gene or so genes that we feel have some association with increased risk. So again, not all these gene mutations are what we consider high-risk autosomal dominant genes. And a lot of these genes probably account for familial cancers. So when we see a family and there's multiple breast cancers or there's multiple colon cancers, we do the germline testing and we can't find a mutation, but there just seems like there's something going on. So as I was going through my talk last night, Ash was kind enough to point out that some of my slides are very, very wordy. My goal here is not to read every word. My goal is also not for you to read every word. It's more of just kind of an introduction to all of these different conditions that can increase the risk for an individual to develop cancer or other clinical features. And also, as I'm taking a family history or I'm looking at a constellation of cancers in a patient and or their family, sort of all of these different conditions that I'm going through in my head to assess which genes should we be testing for, what genes could be predisposing this family to this myriad of cancers. I'm going to start with the more common of these hereditary cancer syndromes. Hopefully most of us at this point have heard of BRCA1 and BRCA2. Another condition that's actually just as, if not more common than having a BRCA mutation is Lynch syndrome. It's extremely underdiagnosed. Right now, we do have universal screening for all individuals diagnosed with colorectal cancer, screening the tumor itself to see if any of these underlying gene changes are leading to protein deficiency in the tumor. But overall, I find that a lot of times patients are coming to me and it's very obvious to me that there's a family history of colon or cancer or other cancers that suggest Lynch syndrome, but they're really not being brought to a genetic specialist's attention until there's just been so many cancers in the family. One of the things I really want to point out with these two syndromes is that there's a lot of overlap in the types of cancers that we can see. So with BRCA mutations, we typically, and even patients will typically just think of breast and ovarian cancer, except for in these patients, we can also see pancreatic cancer, we can see prostate cancer, we can see an increased risk for colon cancer, and now there's more and more evidence that BRCA1 mutations also increase the risk for a certain type of uterine cancer. And then we have Lynch syndrome, and again, ovarian cancer, colon cancer, pancreatic cancer, and I didn't put breast cancer up there. It's sort of controversial as to whether or not breast cancer is truly associated with Lynch syndrome. However, some of the data that we're starting to see now that we're doing what we call panel testing, where we're testing multiple genes all at once for a patient, regardless of exactly which gene they're indicated to do testing for, we're finding that more and more patients who actually have MSH6 and PMS2 mutations do not meet criteria for doing Lynch syndrome testing, but they do meet criteria for doing BRCA1 and 2 testing. So they might present to us as looking like a BRCA family, but when we do panel testing, we're actually finding that they have Lynch syndrome because of mutations in these 2 genes. And so we're thinking that more and more families who have classic Lynch syndrome are more likely to have mutations in one of these 2 genes. And then families that maybe have what looks like a hereditary cancer syndrome, we test BRCA1 and 2, and that's normal, we really should be going back and at least assessing for Lynch syndrome. And then of these hereditary cancer syndromes that are a little bit more common than others, we also see the polyposis syndrome. So where a person usually presents with hundreds of thousands of colon polyps, they're very high risk for colon cancer. We know that there's an autosomal dominant condition that's caused by mutations in APC. And so usually these families are pretty striking. They'll have every generation affected with polyposis and colon cancer, usually family members who have died in their 20s or 30s because of their colon cancer. The risk for colon cancer is actually 100% if an individual does not have their colon prophylactically removed once polyposis really starts developing. And then mutations in MUTYH are actually recessive. So in these individuals, they'll present with polyposis, but because they have to have a mutation from each parent, and these parents are actually carriers, then in these individuals, we're not going to see a family history. They're going to be the first person, because going back generations, a lot of family members are going to be carriers for the condition, but it's not until the person gets a mutation from both mom and dad that they're going to develop the polyposis. There's also a few other conditions that are much more rare than having a BRCA mutation or Lynch syndrome or polyposis syndrome, but there's still enough evidence. These are really conditions that were studied before genetic testing was developed, and so because of the clinical presentations, we have a pretty good idea of what it means to carry one of these mutations or have these conditions. Now that we have genes that we can test, we're learning more and more about what it really means to have a mutation in one of these genes. But there's been enough studies to say, all right, who should be tested for this and how should we manage them clinically? So NCCN feels that there's enough published data to come out with guidelines of how we should follow these patients. On this slide, one of the things I want to point out is there's also pretty well-described conditions that sometimes we still don't know the gene. So we can at least give a clinical diagnosis to the patient. We know what we should maybe be offering to the family members because of that increased risk for colon cancer, but we haven't yet identified the gene. So here we get into my really busy slides. Again, I'm not going to read all this. The take-home message from this is that there are multiple genetic conditions that can increase the risk for cancer. Most of these present with pretty characteristic cancers. So like, for instance, these mutations right here, they really mostly present with paragangliomas and pheochromocytomas. Whereas if the family has these specific types of cancers, this is really the constellation of genes that I'm going to want to be testing. Also a very busy slide, but there's also other genetic conditions that have very specific clinical presentations, like neurofibromatosis, for instance, a lot of benign but very burdensome tumors that can occur. But again, these conditions also are increasing the risk for certain types of cancers. So if you have patients with some of these conditions, while they may be followed for kind of their typical presentation of tumors, also be thinking maybe sending them to a cancer genetic counselor to talk a little bit further about what cancer risks are they at increased risk for and the medical management for those. So I went pretty quickly through a lot of those conditions. I do want to present case reports on 3 specific conditions because these are things that have been seen right here in the Gulf region. The first one I want to start with, and this is thanks to Dr. Tan, literally the first week that I started at the Mitchell Cancer Institute. I'm starting a new program. I'm not supposed to be seeing patients for a couple weeks, but this ended up being one of the most interesting cases I've ever seen. Dr. Tan asked me to see a patient that he was pretty sure had what we call familial GIST syndrome. And this condition is rare enough that I actually didn't learn about this in grad school. I had to quickly do some research whenever Dr. Tan asked me to see this family so I knew what I was talking about. This condition is primarily caused by mutations in the KIT gene and then the PDGFRA gene. There are other hereditary conditions that can increase the risk for GIST. However, it's these two genes, they present with pretty much just GISTs in the family. It's not other types of cancers that we're seeing in these families. It's a very rare condition with limited published data. And then individuals with germline KIT mutation, we think, based on the limited data, that there's about a 90% lifetime risk of developing GIST by age 70. So here is a very complicated pedigree. So when Dr. Tan sent me in to see this patient in one of his own patient rooms, he probably didn't anticipate that I was going to be in there for a while, but this patient has a huge family. And so I'm going to really orient you to this pedigree so you know what you're looking at here. But every time I draw this pedigree, the arrow is pointing at the proband, my patient. From there, that arrow is pointing at his siblings. Yes, this is a family of 17 siblings. This generation is his children, nieces, and nephews. We then move up. Circles are always females, so on your right-hand side is mom, left-hand side is dad. Then you move out to his aunts and uncles, and in this line, all of his cousins. So I took this family history. He was not the best historian, but this is what we did get. So he did report that he's fairly confident that these individuals have had actual GIST. So that's not following the typical autosomal dominant pattern where we want to see every single generation being affected, about half of every generation being affected. But then we also had to consider that there's a number of individuals who had some sort of bowel cancer, or they had multiple abdominal surgeries, or they died young from cancer that we're not sure what type of cancer that they had. And then from there, we can also get rid of some of these family members, because he was telling me about a sibling who was stillborn. He was telling me about a sibling who died very shortly after birth. He had a couple family members that died either in their 30s or their 20s from motor vehicle accidents or heart disease. So if we get rid of them, we're starting to see, yes, this really is following kind of an autosomal dominant pattern, and just more suspicious that even if we couldn't find a mutation in this family, it really does look like familial GIST syndrome. So moving on to Peutz-Jeghers syndrome, this condition, again, it's autosomal dominant. It's caused by mutations in the STK11 gene. Primarily with this condition, we'll see hamartomatous polyps in the small bowel. And I'm going to be actually showing you a case that we have at Mitchell Cancer Institute. These hamartomatous polyps, they're typically not going to turn into any kind of malignancy, but they do cause problems because they cause like small bowel obstruction. But these hamartomatous polyps can also develop in other parts of the body. But these individuals are at very high risk for certain types of cancers, primarily breast cancer and colon cancer. We can also see stomach cancers and a myriad of other cancers. One of the interesting ones is that females are at about a 10% risk of a very, very, very aggressive type of cervical cancer. So making sure that if they have a hysterectomy, it's really a complete, total hysterectomy, removing the cervix as well. So our patient at the Mitchell Cancer Institute, I'm going to focus down here real quick. So she is a 40-year-old African-American female. She first presented with mucocutaneous pigmentation. This is a trademark sign of Peutz-Jeghers syndrome. They'll develop, it's almost like a purplish or sometimes brown dots inside the mouth and along the cheeks. They'll often get them on their hands, sometimes their feet and their groin area. She now only has maybe a few hyperpigmented spots on her fingertips. And this is, again, very typical of Peutz-Jeghers syndrome. These hyperpigmented macules will kind of fade over the lifetime. She then had a small bowel obstruction at age 28 and is post-resection. She had a second small bowel obstruction at 39, had a resection. At 39, she was also diagnosed with stage 1, grade 1 endometrial cancer. And then when they removed her ovaries, they did find bilateral sex cord tumors. And then I really encouraged her when I saw her at this point to get a mammogram because she was 40, and lo and behold, she has just been diagnosed with breast cancer. She does not have any family history. So does this really make sense with Peutz-Jeghers syndrome with an autosomal dominant condition? Well, in this case, yes, because we know that almost half of patients that have been clinically diagnosed with Peutz-Jeghers syndrome and have a germline mutation, they're de novo, meaning of new. They were the first person in the family to have that mutation. So it wasn't inherited from mom or dad, which would explain why she doesn't have this family history, even though this is an autosomal dominant condition. However, for her future generations, she does have that 50-50 chance of passing it on to her children. My third case of a local genetic condition, this is something where one of the OBGYNs that I met in the area told me that he has a pretty large family. So I have not actually met this patient. I don't have a lot of clinical information on her, but he told me that this condition is in a family in this area. So this, again, it's an autosomal dominant condition. It's caused by mutations in the FH gene. With this particular condition, it's very, very common that females will develop uterine leiomyomas. We can also see cutaneous leiomyomas, and I'll talk a little bit about just kind of the typical clinical management of those tumors. But then also, more importantly, is that in these families, these individuals have about a 10 to 16% risk of developing a very aggressive form of renal cell carcinoma. And with these individuals, it's almost always unilateral. So if we keep that in mind, and when we go to the medical management, with the cutaneous leiomyoma is just an annual dermatologic exam. They also follow the uterine leiomyomas like a typical fibroid, basically, just when it becomes burdensome, they go ahead and do a hysterectomy. But when it comes to these renal cell carcinomas, it's so important to screen them, and as soon as you're suspicious that they have one of these tumors, to just go ahead and remove the kidney. Again, in most of these patients, they'll have unilateral, so the thought is that their other kidney will not be affected, but because it's so aggressive that it's important to take that out as soon as we're concerned that there is one of these renal cancers. So if I've kind of lost you at all, or you're starting to, your blood flow has gone to your stomach and you're losing interest, this is really what I want you guys to take to clinic though. So I talked a lot about these cancer syndromes, but really, when is it important to send me a patient? And one of the things I want to say before I get into this is, don't worry about over-referring. Don't worry about sending me maybe referrals that aren't completely appropriate. I would rather see a patient and take a detailed family history and be able to reassure them, no, I don't think that you have a mutation, than to be missing patients that really should be seeing me. I'm always happy to answer questions before you do send a patient to me if I think it's appropriate or not, but I can guarantee the vast majority of the time I'm going to say yes, because I would rather sit down. It is amazing what patients will tell me about their family history when I actually sit there and ask about each individual aunt and uncle and each individual cousin. I had a patient that was referred to me in her medical records and to her physician. She just told him about one person who had breast cancer, but as I sat down and talked to her, all of a sudden she just started crying as we got about halfway through her family, and she said, I never thought about this, but now that I'm sitting here talking to you, almost half of my family members have cancer. And she had never really thought about it until I really walked through the family. So I would rather rule out genetic testing than not be sure. So this is in your handouts, in your little booklets. I have not changed anything since I handed in my PowerPoint. So always, you can go back and refer to this. But indications for referral to genetic counselor, this is a personal or family history of the following. If we see cancer diagnosed at a young age, and really focusing on these types of cancers here, multiple primary cancers in the same individual. And on some level, use your discretion. I'm not talking about a heavy smoker who had a lung cancer and then a bladder cancer. But once you kind of can safely rule out some of these environmental factors, if someone has had 2 primary cancers, feel free to send them to me. I will assess from there. I've had a patient before. She was in her 80s. She had survived 6 primary cancers before she was finally sent to me. The family history was riddled with cancer. All I had to do was finish the family history to say, you have Lynch syndrome. I'm not always right with my predictions, but sure enough, she had Lynch syndrome confirmed with germline testing. But don't let your patient be that one who gets to 6 cancers before they finally come to see me. If we see cancer in 2 or more close relatives, again, I don't care to see 2 individuals who have lung cancer in a family of smokers. But if you do start to see 3 breast cancers in one family, per NCCN guidelines, none of them have to be under the age of 50 in order to meet criteria for testing. I've never found a BRCA mutation in a family where it's 3 individuals over the age of 50 with breast cancer, but it can still happen. It being, they can still have a mutation even though they're not presenting with young breast cancers. Also, if we see a combination of certain cancers throughout the family, and then also focusing on single cases, so whether the patient, a first-degree relative or a second-degree relative, has had ovarian cancer, they are appropriate for genetic counseling. If an individual themselves has had a sarcoma, medullary thyroid cancer, retinoblastoma, Wilms tumor, yes, I will see pediatric patients just because there's no other genetic counselor in this area that will see them. Adrenocortical carcinomas, chorioplexus carcinoma, and then these pheos and paragangliomas. Also, when we talk about these polyposis syndromes, if an individual has had more than 10 adenomas throughout their life, this recently came up with one of the physicians. They were asking me, all right, well, do they meet criteria for doing genetic testing if they've had more, or if they've had exactly 10 adenomatous polyps during their lifetime? And NCCN guidelines a couple years ago actually changed the guidelines to say, no, if they've had 20 throughout their life, then we can go ahead and do testing. But at least having 10 is good enough to get them a referral to genetic counseling, and I will assess from there. Also, any number at any age of hamartomatous polyps, juvenile polyps, or serrated polyps is enough for an indication for referral for a genetic counselor. And then this is my very last slide. Hang in there, guys. Okay. So these are, I love this slide. I stole it from Banks et al. And they go through the top 10 cancers that it does not matter what the rest of the family history looks like. If a person has one of these cancers, they're very likely to have a germline mutation in the gene or for the condition that I put in the parentheses after. So if you ever see a patient with adrenocortical carcinoma, any type of carcinoid tumor, diffuse gastric cancer, fallopian tube cancer, a leiomyosarcoma, medullary thyroid cancer, paraganglioma or a pheo, renal cell carcinoma, particularly these chromophobe hybrid, or I'm not even going to try to pronounce that one. And then sebaceous carcinomas, these don't have to be malignant, even sebaceous neoplasms are very indicative of Lynch syndrome, and then those sex cord tumors. So this is just my reference slide. Again, I'm not going to read through that. This is the way to refer to me. We really prefer that providers just call the main number at the Mitchell Cancer Institute. The schedulers are trained to be able to get patients onto my schedule and ask the appropriate questions. But you can always contact me directly as well. And again, that's in the notebook if you have any questions about referring a patient or about appropriateness for referring. So, and then hopefully everyone can now pass the post-conference quiz. But when we talked about a lot of overlap with some of these cancers, out of the following conditions, which one increases the risk for ovarian cancer? Anyone? Anyone? Yes, thank you, all of the above. And then genetic testing in an individual with a personal history of cancer will not impact the patient's medical management plan. All right, before we even answer this. Correct, all right, thanks. That's right, thank goodness. But okay, so I'm going to say something about this real quick because I have a couple minutes. But I have patients who come in all the time and they're like, I've already had cancer. Why should I do testing? 1, you could be at increased risk for getting another cancer. I would like to prevent that for you. 2, if we're doing genetic testing in a family, I would rather test someone who's had cancer because they're more likely to have the germline mutation. That's going to be more informative for all your other family members. If you have 5 kids and I start testing them, even if they all come back negative, it might be that they just did not inherit that mutation from you. So I'd rather start with you, the person that's more likely to have the mutation, and then go from there in terms of testing the other family members. 3, and this is kind of interesting, but we're really in the very beginning of understanding how these germline mutations can impact clinical care. We do know that individuals who have ovarian cancer due to a BRCA mutation, FDA has approved PARP inhibitors for these individuals. We also know individuals who have colorectal cancer and have a microsatellite unstable tumor have a different prognosis than those who don't have, or their tumor is microsatellite stable. So the more that we learn about the biology of the tumor, one part of it is, was this person born with a germline mutation to begin with? And one of the things I wanted to come back to, Dr. Lyles was talking about treatment of pancreatic cancers and how it's kind of abysmal. Well, some of these pancreatic cancer patients have BRCA mutations. What if we can give a PARP inhibitor to these individuals and actually do a much better job of treating them with lower toxicity? So it's something where, of course, I care about testing for you, even though you've already had cancer, because this could end up having a big impact, not just on preventative, but also treating your current cancer. Again, we're in the very beginning of understanding how these germline mutations can help clinical management in terms of treatment of cancers, but it's still, we're getting there. So, and that is the end of my talk.